I'm gonna move all that other tissue out of the way until I feel the groove, and I'm just gonna slowly strip with deeper pressure. The way that I add pressure is I can alter the shape of my spine to either apply more pressure because I'm using my abdominals to create more tension, or I can release if I feel like there's a tender point that I want to avoid. You can also play with rolling your body towards and away from where you're working to help build that pressure without having to curl your fingers much more. How's the pressure feeling? Like an 8. Okay, so much deeper pressure. Okay, to use the analogy, all this is in your book. I just edited it to make it easier to follow along. You'll take your thumb, you'll support with your fingers. For this one, I suggest moving from superior to inferior. I think it's a little bit easier than dragging your thumb this direction. You'll again just feel for that lamina groove. Apply pressure by leaning in and slowly strip down the spine. Okay, so while I do this, and this is being filmed, can I have someone else read deep stripping on the scalenes?
The client is in a supine position with the head turned slightly away from the side being treated. Use the fingertips or thumb to perform a longitudinal stripping technique on the interior and middle scalene muscles, just lateral to the lateral edge of the clavicular head of the sternocleidomastoid. The entire length of the muscle is not accessible with this stripping technique, so just treat the accessible fibers. Do not exert a great deal of pressure in the anterior neck region, as the brachial plexus and vascular structures are superficial in this area. If the client reports an increase in neurological or vascular symptoms, immediately cease the technique, as there may be additional pressure on the primary region of pathology.
Okay. So, like we mentioned, these are the lateral flexors. We have our scalenes, right? They're moving from the transverse processes down onto the first rib. So it's mentioning that we want to use our finger or the thumb to perform the stripping. The whole thing is not going to be accessible because we don't want to apply too much pressure and endanger insight. So if we want to work these lower fibers, we just feel where they're at and palpate for them. Sync the pressure, check in. What number would you give this? 2 to 3. Do you mind if I increase it to 5? Just let me know when we get there.
Cool.
Okay, we're at a 5 now. So my goal is to maintain that pressure as I gently strip down towards the rib. Great. All right. Next one. If you don't mind moving the screen down, Jamie. And then can someone please read number 3? Either Nikki or Mesta or Zaire.
Deep stripping on pectoralis minor. The client is in a supine position. Perform sufficient forming techniques such as effleurage and stripping cross fiber to reduce tension in the pectoralis major muscles, so the pectoralis minor is more easily accessible. Perform a deep longitudinal stripping technique on the pectoralis minor, beginning at the coracoid process of the scapula and moving inferiorly to its attachment on ribs 3, 4, and 5. Pressure is applied directly through the pectoralis major muscle, and this region can be somewhat tender, so use care in the amount of pressure that is applied. Immediately move off the area of the technique reproduces or exacerbates neurological symptoms.
Thank you. So I spent that portion of time doing some of the effleurage strokes, right? And then now I'm doing some of these more like cross fiber sweeping motions with my finger knuckles. You notice how Tyler's arm has moved away from being at the side to kind of coming off a little bit. That lets us know that we're sort of relaxing these muscles, helping them let go and giving us more access to the tissues of the pec. So now that we've warmed that up, I'm going to get into pec minor. So I'm going to palpate for the coracoid process. Something that you'll feel when you're doing work with pec minor is that you've got the superficial pec major moving in this direction. Pec minor moves perpendicular to that, starting at the coracoid process and then attaching on ribs 3, 4, and 5. So it's pretty easy to palpate because it'll feel like this bundle of tissue that's running perpendicular to pec major. Your client may also note that it feels a little tender. So from there, I apply pressure. What number do you feel right here with this pressure? A 3. Stand up a little bit, see if I can lean more, provide some more pressure. What are you feeling now? Like a 5. Okay, so I've applied the 5, but this doesn't feel like I can move anymore, so I'm just gonna step back a bit so I can, oh, and I'm also gonna hold this, it feels better, so that I can apply pressure down pec minor. Watching your client's breath, noting if there's any wincing, and then releasing. Okay. Who can read this first D section for me?
Static compression and stretch to reduce muscular hypertensity in a specific location. Use static compression methods to treat localized areas of tension or specific myofascial trigger points with small contact surface pressure. Finger pad knuckle. 8 to 10 seconds of maintained pressure is usually enough to achieve a reduction of muscle tension.
And then Jamie, can you swipe? Okay. So I just want to note here that for Tyler specifically, as I was working with pec minor, it felt like this could benefit more from some circular friction or some cross fiber work. So I took my finger pads and I started creating more of a circular motion to help release pec minor, and then I started stripping in that direction after I used the circular friction. Okay. So now moving into static compression of the suboccipitals. I'm just gonna read this one myself. So I'm gonna hold the client's head with both hands, resting my fingertips on the suboccipitals. Boom, right? You'll feel that bony landmark of the occiput. From here, you wanna apply static compression with the fingertips or the thumb to this post-cervical and suboccipital region, one side at a time. So I've got the head cradled here. I'm gonna release on the left so I can hold the neck in place. Then I'm gonna curl my fingers around the suboccipitals and lean back and hold that for about 10 seconds. How's that feeling? Feels good. Okay. And then static compression with head rotation. I'm going to scoot around this way, so make sure you find a way to stand around so you can see what's going on. Oops. So, gently rotate the client's head to the opposite side. The book says to use the hand. For some reason, I feel not always comfortable touching people's faces with my hands, especially if this is orthopedic work or it's our first time working together. I'll often place the fleshy part of my forearm across them and move their head in that direction. It feels a little bit less invasive. Also, if your fingers are really tired, you'll feel them kind of like shaking a little bit, and to put like an uncertain hand on someone's head can feel odd. So I use this. So with the other hand, you'll place the thumb on the suboccipital region. And then from here, you'll bring the client's head back towards neutral and hold static compression that way. How's that feeling? Like a good 5 or 6. In that way, you don't have to use as much muscle to work with the client's suboccipitals. You just put your thumb there and then rotate their head onto the tool that you're using. And then you hold the static compression until there's some sensation of tissue release or the client reports a reduction in pain sensations. Cool. Now that same pin and stretch idea, or sorry, we're gonna start incorporating pin and stretch. I'm gonna scoot back over this way. So the client's supine, practitioner to the level of the client's head facing their feet. Place the thumb or the fingertip in contact with the pec minor, but not on any area that exaggerates or produces their neurological symptoms. Instruct the client to reach as far forward towards their toes as possible. This motion is going to depress the scapula and puts the pec minor in a shortened position. When this muscle is in this position, you apply the moderate pressure with moderate to significant pressure within the client's comfort to the pec minor muscle. And can you scroll the screen up one more time? Then you instruct the client to hike the shoulder up as if bringing it as close to the ear as possible. And while they're elevating the shoulder girdle, apply static compression or a short stripping technique to the pectoralis minor muscle and repeat this several times to encourage the lengthening of the muscle. So go ahead and relax, and we'll put that all into one solid go. Tyler, can you please reach your hand down towards your feet? This places the muscle in its shortened position. Now I'm going to apply pressure. I can do that seated or I can be standing. Perfect. And now can you lift your shoulder up towards your ear? So as he's lifting up, I'm taking the tissue that I'm holding and pinning it down, thereby stretching the pec minor. Cool. And go ahead and release. Another way to do this so that your client is not active. Mind you, this is thoracic outlet syndrome, so if they're feeling neurological symptoms, abort. That you can take the muscle and take the arm, and instead of moving their shoulder into elevation, you move their shoulder into elevation. Finding that place where the tissue feels supple, sinking in, and creating the stretch. How's that feel? And release, and return the client's arm back. Okay. This one, we don't have to read the full thing. It's pinning and stretching of the sternocleidomastoid muscle. Has anyone tried to do that before? So, I'm gonna rotate to this side so I have access to the tissue. With some clients, it may be difficult to see where the SCM is. So to do that, you can always ask them to help. So I'm gonna place one hand on Tyler's temple here. And Tyler, can you please very gently try to bring your head up towards the ceiling? And now we see it fire, right? So that's where SAM is. That's where I'm gonna focus my work and go ahead and relax. So now I'm gonna take my thumb and my forefinger. Typically it's best to do this without a whole lot of emollient, but we can do this. Okay. What I'll do is lift the head a little bit more and move it into contralateral rotation so that I can hold onto the tissue and then gently bring them back to neutral, thereby stretching the tissue. Does that feel okay? Yeah. Okay. This is a tricky one. You'll feel it slip out of your fingers. It may take a couple goes before you really understand where it's at, but no worries. Again, the idea is rotate the head slightly so you have access to the tissue. Ask them to engage it if you need to so that you can see it. Grab onto the tissue. If you need to, you can put them further into contralateral rotation and extension, and then bring everything back. Ipsilateral rotation and a little bit of flexion. And then let it go. All right. Thank you, Maestro. Active engagement techniques. I'll read this one. Massage with active engagement for the cervical extensors. An effective way to treat the chronic muscle tension in deeper neck muscles is to use active engagement lengthening techniques. The client is in a supine position. Place one hand to hold the head while the other hand performs the stripping technique on the cervical muscles, as in the deep stripping techniques that you saw in C and in E. So you'll instruct the client to push their head down with a moderate amount of effort into the hand that's holding the head. Once a moderate isometric contraction is established, instruct the client to slowly let go of the contraction and gradually lift their head into full flexion. While they're releasing the contraction and the head is moving into flexion, perform a deep stripping technique on the cervical extensor muscles. It's easiest to perform this stroke moving down the neck in an inferior fashion. So, I'm going to step myself up at the base of the neck because I want to move inferiorly. I'm probably going to use my thumb. So, Tyler, can you please push your head down with a moderate amount of effort into this hand, down towards the table? Cool, I feel that happening. That means that the cervical extensors are engaged. From here, now I want you to slowly let go of that contraction. As he lets go, I start to lift the head and apply the stripping technique along the extensors. Client's in full flexion, and then we come back down. And you repeat that as many times as you need. One more go. Alright, tell her one more time. Just gently press your head down towards the table. For 3, 2, 1, and release. How's that feeling? Okay. Release. And all the way down. All right. Next up, massaging with the lateral neck flexors. The same technique can be used to perform it on the lateral neck flexors. I'll fix that typo later, instead of the cervical extensors by altering the position slightly. Have the client attempt to laterally flex the neck to the side that's being treated while resistance is offered to that action. Instruct the client to slowly let go of the contraction, and as they let go, gradually pull or push the head to the opposite side. As the client's head is slowly moving to the opposite side, perform the stripping technique. Okay, so for this one, I'm going to use my thumb to kind of gauge where I want to work, but it's also going to be the hand that's resisting the motion that we're trying to have him do. My favorite way to describe moving the head to the side is to ask the client to move their ear towards their shoulder, because that way I get lateral flexion instead of rotation, because sometimes your clients do that. Okay, and Tyler, can you please try to bring your right ear towards your right shoulder? And release. And as he releases, I move the head to the left and I strip the lateral flexors down towards the rib cage. One more go. All right, one more time. Go ahead and press your head into my hand, right ear towards right shoulder. Good. As he releases, go ahead and let go. I move the head and I strip the tissue. Okay. Massage with active engagement. This one says it's performed best without lubrication on the skin, but we've already put on some emollient, so we're just gonna try it out. The client's in the supine position where the head can be relaxed and off the edge of the table or a bolster. First, I'm just gonna read this one, then we're gonna do it. One hand holds the client's head and the other hand is positioned over the scalene muscles or their distal fascial connections. You can ask the client to lift their head out of the hand and hold it there for a few seconds, but you keep in contact with the head. And then after holding that contraction for 5 to 8 seconds, instruct the client to slowly let go of that contraction. As they slowly let go, let their head drop back into extension while applying an inferiorly directed traction force to the scalenes and the fascial tissues. The force of the fingertips pulls on the skin and the superficial fascia more than pressing down on the scalenes. Repeat this technique several times. Okay, so Tyler, I'm gonna have you scoot back so that your head is off the table and I'm gonna hold your head while you do that. And this is just in an effort to move the head further into extension than they could if they had their head resting on the table just a little bit further. Now, mind you, if somebody's got thoracic outlet syndrome or whiplash, you want to be doing this very, very carefully and very slowly. So, first thing we want to do is ask the client, can you gently try to lift your head up out of my hand? I'm going to follow you as you do that. So now he's using his neck flexors to lift his head, thereby releasing some of the scalene tissue and, of course, the extensors. And now I want you to let go of that. I'm going to hold your head for you and bring it down. So I'm really just using light pressure here. I'm not trying to press down on the scalenes. They're quite accessible in this zone, but I'm moving his head further down into extension. Does it feel okay? Great. All right, go ahead and scoot back down. Oh, yeah. All right, and then Jamie, can you show us this PNF one? So for this one, the right side is being treated. This is for SEM. This is specifically for spasmodic torticollis. So you're treating the right side, but you would reverse these instructions if you wanted to treat the left. The client is supine. You place one hand gently on the right side of the client's forehead. You instruct the client to attempt to rotate the head to the right while offering some resistance for about 5 to 8 seconds. This is going to engage the left SEM and also the right ipsilateral rotators, but we're working with right SEM. Then you instruct the client to release that contraction, and as they let go of the contraction, you gently turn the head in the same direction that they were moving towards the right, and this will stretch the SEM. So this isn't really about applying pressure. This is really about using reciprocal inhibition to try to get that right side to relax so you can stretch it further. So, one hand is placed gently on the right side of the forehead. I want you to attempt to rotate your head to the right. That means your nose is gonna move from the ceiling towards the wall to your right. All right, and now I'm offering some resistance by holding the head in place here for about 5 to 8 seconds. So 3, 2, 1. As they let go, I attempt to move the head further to the right in the direction they were trying to go. Hopefully we get a stretch. And you can do this as many times as far along that line as you can as you get more access. One more time, can you keep trying to rotate your head down towards the table? You resist that motion, right? You can see the left side is firing to make that happen. That means the right side is relaxing. And release. And you move further. This may not stretch your SEM, but somebody with a really spastic SEM, it may be quite helpful. Okay. We're gonna skip these other PNF techniques because you'll read them, it'll make sense. You wanna get the antagonist to contract so that the agonist relaxes, and then you stretch or you apply pressure to them. Let's get into this neuromobilization so you can all get to work. So, neuromobilization is helpful to reduce binding and restriction of the nerves of the upper extremity that could be affected by entrapment near the thoracic outlet. Most thoracic outlet variations affect the ulnar nerve, right, innervating the pinky and the ring finger and all along this medial dermatome. And so this variation is going to be about the mobility of that ulnar nerve. So the client is in the supine position with the arm at the side. You're gonna hyperextend the client's wrist and the elbow, and the fingers, and bring the forearm into the position of elbow flexion. So, hyperextending the wrist and the fingers, bringing the arm into elbow flexion. I'm gonna do that with my inside hand. Then it says, from that position, abduct the shoulder so it appears the client's hand is moving close to covering their ear. So we're gonna keep going. We're gonna abduct the shoulder until it looks like the client is trying to cover their ear. Right? This is going to be the last step that we do, and then we're gonna ask our client, can you bring your left ear towards your left shoulder? As far as you can. Once they get to that point, the nerve is as stretched as it's going to get, okay? And then you ask the client to bring their head back to neutral. Come on back. and you release because you don't want to hold that for long. Remember, neuromobility is more about moving it to its end range and letting it go and repeating than it is about holding the position. So then we go again. When you feel like your hand's close to your ear, go ahead and bring your left ear towards your left shoulder, and then bring it back, and you release. And you repeat as many times as possible. Remember that in the contraindication, can you tell me that you feel pain right when I start to move your elbow?
No.
Okay, so, right, this is, maybe a client feels like this is as far as they can stretch, right? Then you listen to that. You're free to do it as long as they're comfortable, but you don't move past that point.
Oh, I wasn't feeling pain.
I know you weren't.
Oh, okay.
Yeah. You said no, and I just assumed, like some of your clients are gonna say that. They're gonna say no, or ouch, or something, and that's gonna be your cue. Okay? Questions about that neuromobility technique, or really anything that I've done so far? So you all really have the basics. You have myofascial release, you have effleurage, you understand static compression, you know your P and F things, you just have to apply it to specific muscle groups. You may have now just learned a new neuromobility thing, but it makes sense. You've got the ulnar nerve, you're stretching it here, you're stretching it here, you're stretching it here, you're having them stretch it, and then you bring everything back to normal. Cool. Let's let Tyler get dressed. I'm gonna show you these last special tests, and then partner up, and we'll start to get to work, okay? Positive for that result. So just to read the protocol here, the client is in a seated position. You gently press down on the top of their head, gently. You'll see some videos where people are pressing like this down on the head, but if they're dealing with like an acute or severe compression, you just want to go light, you want to go slow. It's most likely that their symptoms will be recreated if you do that. You can do one hand, or you can do a very soft two-handed version. The test is positive if there's a reproduction of neurological symptoms. Again, often it's going to be brachial plexus, and that's going to be traveling down the ulnar nerve. Okay, cervical compression test. Thoracic outlet syndrome. This is the Addison test. This tests for brachial plexus testing the brachial plexus between the anterior and medial scalenes. So the client's in a seated position, you bring their arm into external rotation, so the palm would be facing out. Abduction is going to be lifted a little bit, and extension. A little bit of extension means behind the shoulder. Okay? From here, Tyler, can you please extend your neck, look up towards the ceiling, and then rotate your head a bit to the same side of the arm that I'm holding. And now take a deep breath and hold it. 3, 2, 1, and release. Cool, go ahead and let go. Come back to normal. So we've put stretch on the structures of the nerve. We've asked the client, go back into extension and rotation, to put even more pressure between the anterior and the middle scalenes, and then we increase the intra-abdominal pressure. Take your deep breath and hold it. And so if this client is dealing with a compressed nerve, they're likely to feel symptoms here. Go ahead and release and let go. If while you're if this fails and you work with them, but then you work on pec minor or you work just below the clavicle and they're like, I'm getting that feeling here, then it may be pec minor syndrome, it may be the clavicle syndrome, or it may be that fourth syndrome where we can't treat it because it's more of a bony thing. But this is a pretty good metric for how to use the Addison test to see if it's anterior scaleral syndrome. Cool. Whiplash. Valsalva. This is pretty much what we just did without the arm use. So this is somebody with a traumatic injury that's having neuropathy down the arm or in the shoulder blade or in the chest. The client's in a seated position. Tyler, can you take a deep breath and then hold it for just a few seconds? Building up pressure inside. And then make your lips tight and exhale that air slowly. Some clients are going to find it easier to do it this way. One more time, take a deep breath, and hold it, and then take the back of your hand to your mouth. And now gently, through pursed lips, push the air into your mouth, into your hand. So what you're doing here is getting the client to create intra-abdominal pressure that puts pressure on the nerve. If they recreate their symptoms in this, if they have shooting pain down the arm or in the neck or in the shoulder blade, then they're testing positive for neurological activity as it pertains to whiplash. Okay? Last one is distraction. This is the only one of these tests where it's positive if there's a reduction in symptoms. Last time, have you lay down on the table face up. This only works if your client is walking in currently with some kind of shooting neurological pain. Then you'll say, okay, let's see if this is a cervical compression issue or something that's associated with your whiplash. You'll bring your hands behind their neck, find their occiput, seated or standing. You're gonna create a little bit of traction, longitudinal traction, releasing some of the compression of the cervical spine. If your client reports a reduction of symptoms, then we know that they're probably dealing with a compression issue. In the case of whiplash, it means there's some kind of joint instability that somehow us doing this is technically treating and releasing some of that pressure. So one more time, you'll take your hands, find some way to hook the occiput or hook the mastoid and create some traction. If there's a reduction of symptoms, they've tested positive for the distraction test. Cool. And we release. Thank you, Tyler.